Here's case 2 for EMT. The prerequisite learning that will have occurred but prior to this would have been you will have completed case 1 with all the things that we learned there. And now we need to also make sure that you know how to make appropriate decisions about scene safety when you're faced with information in the dispatch that would make you think that some violent things are going on or have gone on at that scene. In your first case, you went to a guy vomiting blood in an office setting, and so the scene safety issues were minimal other than PPE from body substances. But in this case, we're going to give you a little bit more challenging sort of scenario. And then we need you to be sure you can do external bleeding control, manage long bone and joint injuries. And the only real terminology for this one is distal CMS, which you should already be aware of from your work in lab setting. The system info at the time and day is now. You have a very short 1-minute response time. We want you to be able to work with this sort of a situation where you need to make decisions pretty quickly because you're very close to the scene even when you're even at dispatch. There is a transported ALS unit that's 8 minutes behind you, a little bit longer wait time now than in your first case. You're still a BLS first response unit, and we still have the same location of hospitals. You can be on the way toward the trauma center, and in the same direction is the full service ER that you can stop at, or you can go 5 more minutes on to the trauma center if you decide this guy needs trauma center. Again, even though you're playing the BLS first response role, we want you to think through this as though you were ambulance staff. So I apologize for the formatting there on that slide, but that says Delta response hemorrhage at the Casey's convenience store in Hallsville at the corner of 124 and Route B. Fairly standard intersection, 4-way intersection of 2 major highways in a small town north of Columbia at a Casey's. So are lights and siren indicated? Absolutely. And you're coming from a station on Route B, again, a minute up the road, a very short, straight route. And so you respond on the radio to the dispatch and say that your unit is responding. And the dispatcher comes back with further information that says the patient has gunshot wounds and law enforcement is on the scene. Now you have to make a decision. So pre-plan wise, you're thinking about, what about my patient? Well, he's got gunshot wounds. That could be internal and external bleeding, which could lead to hypovolemic shock, and it's probably a critical trauma patient. But the other thing you need to think about, and probably before you think about your patient, is where's the guy that shot your patient? So there's some decisions to be made here. When you pull up, it's a typical convenience store. It's the corner 4-way intersection of 2 main roadways. There's 1 officer on the scene, more on the way. It's fairly chaotic, and so the first person you need to talk to is that police officer. The officer tells you that the shooter drove away. We're pretty sure. There's 1 victim located in the grassy area behind the building, and at this point, you're going to need to engage with that patient and let the cop be the cop. Is it possible that the shooter's going to come back? Absolutely. Is it possible that the shooter's hiding somewhere? Absolutely. But in this case, you have a patient who's shot, who's sick, and you don't have any clear reason why you can't go take care of him, and you need to jump in and incur a little bit of risk because there is significant ability on your part to treat the patient. So there is some benefit, and we will risk a lot when there's a lot to be saved, and so that's the decision right now. You go around behind the convenience store to the grassy area. There's a bystander holding pressure on a wound in the guy's belly. He's screaming about his ankle, and he looks like he's about 20-year-old male. You walk up, you say, "How you doing?" He says, "My ankle hurts." He's screaming. He's in great distress. "What's your name?" And he gives you his name. "How old are you?" And he gives you that. So you know his brain's working. You also know his lungs are working because he's screaming. Next thing you check on is his radial pulse. There is one. It is rapid. It is weak. His skin is cool, pale, and moist. And so right now you know that he's in hypovolemic shock. His ventilatory rate is fast. It's non-labored, good depth. There's no cyanosis. So very much like the first patient, the first case that we ran, where you had a guy with hypovolemic shock, and it was really just a circulatory problem. There wasn't any ventilatory or oxygenation issues. Your urgent action is control external bleeding. Find any open chest wounds and seal them up. So that's your very first thing to do, and nothing else needs to happen until that happens. There shouldn't be any asking of history questions or obtaining a blood pressure. You've got to find and control any external bleeding and deal with any wounds in his chest. You're going to prep him for immediate transport. Sure, it would be nice if you could transport, but you can't. So you're going to have to wait for the ambulance to get there, and just like in case 1, you'll probably need to provide them with some assistance. This patient's going to be fixed at the trauma center, not on the grassy area behind the convenience store. You'll treat him for hypovolemic shock, as you know. O2, keep him warm, rapid transport. Is there internal uncontrollable bleeding? Well, if there is, you're not going to be able to control it, so that's going to be done at the hospital, and supine will probably work for this guy. Gather some more data and info. The ambulance is not arriving immediately, so you do have time to get vitals. Again, if the ambulance pulls up, stop getting the blood pressure, get the patient in the ambulance. But in this case, you're able to measure a pressure of 110/80, heart rate of 130. He's actually breathing 30 times a minute, if you actually will count it, and his pulse ox reading is quite good. History of present illness, you're talking to the guy while you're getting some vitals, and you say, so what happened? And you get a story, a fairly dramatic story about an attempted armed robbery, or I guess maybe it was an armed robbery. Anyway, a guy with a gun comes in the store and shoots the clerk once in the belly, and then the patient, who was the clerk, jumped over the counter to get away, and that's when he messed up his ankle, and he got around behind the store, and he thinks the bad guy drove off. Past history and meds, really nothing going on there, but it's always good to ask. It's part of a conversation. And then we have this gather data and info where you're going to do a rapid trauma exam, and you find one belly wound, just lateral to his umbilicus. Lung sounds are good. His belly is rigid and tender, as you would expect, and there is an open deformity to that right ankle. The right ankle looks really bad. So now think and act. What's going to kill this guy? Is the right ankle injury going to kill him? No. It's the belly shot. It's the internal injury, the one that doesn't look as bad and the one that he's not screaming about. If the ambulance is not there yet, let's get some vitals. Again, as you can see, we're trending in the wrong direction. Pressure's going down, heart rate's going up. Next step, repeat vitals and then manage that ankle injury as appropriate. If you could transport right now, management of that ankle injury would be hold it still on a backboard, put him on a cart, get him in the ambulance and go, and deal with that ankle as you're going down the road. But since you can't transport right now, then we need to do something in that direction of managing that ankle injury. If he didn't have the belly shot, we would be able to take the time to make a very appropriate ankle splint. But he has other higher priority injuries, even though he's only complaining about his ankle. Your handoff to the ambulance, pretty straightforward. He's got the ankle fracture, but he's also got a belly shot. He's weak and dizzy, no radial, cool, pale, and clammy. Here is actual vitals. And so now the ambulance is on the same page as you are within the first few seconds. They understand the priorities. They're thinking along the same assessment plan as you are. Here's what the inbound report would sound like. Again, you can stop the video and read that if you need to. Here's what your handoff to the ER would look like and sound like. We're talking about important things first. Then here's your self-debrief, same stuff. So what about gunshot to the belly? Do you need to review maybe where is the liver, where is the spleen, where are things in there? And then how can you transfer this learning to other cases? What if you had external bleeding that was harder to control? In this case, you were probably able to control that ankle bleeding pretty well, pretty easily, But what if? What if your direct pressure doesn't work? What if your first tourniquet doesn't work? Those kinds of things. Here's your written report as a first responder. Again, you can stop the video and watch and read through this. And with all these cases, we give you, provide you an electronic copy of the slides in a PDF format, so you can go through these at your own pace and more than one time. Here's your written report from the ambulance service side. And then again, your same video debrief. And I don't want to gloss over that, but I also don't want to drag out the length of the video talking about stuff that you can read and you already understand. But this is important. This is the video debrief that you do after the call, as well as later that day and a couple days later. This is a fairly dramatic call. This will be on the news. And so, you get a chance to kind of relive this a few times. And every time you do relive that call, try to find some learning in there so you can be better at your next one. Questions you should ask, again, when and why did you know he was in hypothalamic shock? What was your O2 therapy? What if that belly shot wasn't in the belly? What if that gunshot was in the chest? How does that change? And then what if we couldn't really control the bleeding, like I said? So you're talking about preparing yourself for future calls by going on actual calls. And that's the end of case 2.